The thought. This is the good evening, everyone. And this initiative of starting the ISU clinic under the aegis of ICCM, that is the thought process of our Honorable President-elect Dr. Ranveer Singh Tyagi, and he has started this clinic, ISU, ICCM ISU clinic, where the practice meets purpose in critical care. So, in this continuations, today we will discuss about the case on organophosphorus poisoning. And for this case discussion, we have the respected examiner Dr. Rumta sir. He's all know the well-known academic face and our guardian, our ideal for the critical care medicine. And sir has given his valuable time to discuss about this organophosphate poisoning as an examiner. And along with this, we have the Dr. Ashish Bhalla sir. Sir is also well-known figure in the toxicology field. Sir is a professor from PGI Institute of Medical Sciences, Chandigarh. And both, I think Ashish sir will join very soon. Along with this, we have the mentor for this organophosphate poisoning, Dr. Sweta Patel. She is a consultant, senior consultant from the Medanta, the Medicity, Gurgaon. And the case will be presented by Dr. Cecil as well as Dr. Simar. Both are the IDCSM candidate from the Medanta, Medanta, the Medicity from Gurgaon. Uh, I am very thankful to Dr. Ranveer Singh Tyagi sir for giving this opportunity to host as a course director along with Dr. Venkatraman Kola, who is my colleague as well as very energetic persons and always helping me to each moments and will decide how to approach the and how to decide the different cases in different months. So now I request to all both students, Dr. Sisir as well as Dr. Simar, to start a case. And before that, I request to Rumta sir as well as request to Dr. Venkatraman Kola. If you want to say something, then you can say, and then
No,
we will
no,
start and
no,
hand
no.
over the mic to both of you.
Yeah, thank you, Dr. Vikram. We will please go move on to the Rumta sir and Ashish sir for the case. Over to you,
Yes.
sir.
So
Rumta sir.
Venkat sir, now, yeah, move. Rumta sir, please.
No, I think we should start the case immediately without
Yes,
wasting
Yes.
time, and then subsequently, after the case is discussed, we will discuss.
yes.
Yes,
Yeah,
sir.
okay.
Thank you, sir.
So,
Good afternoon, everyone. I am Dr. Shishir, and with me is Dr. Simar. Today, we are going to present a case on organophosphorus poisoning.
Sister,
We have
uh, can you make it in a slideshow?
slides here. It's starting, ma'am.
In slideshow. You have to press down.
Make it full screen. Make it full screen.
Is this okay?
You have to make it full screen.
Actually, it's full screen in my computer, ma'am. I've already done it full screen.
Okay, so is there any
I think it's a specific format with full screen.
No,
It's
no,
a slideshow.
you can actually stop sharing and again open it. That
okay.
will be make it full screen.
Okay.
Kindly share. Are you not able to share the screen? Please share.
I'm on it, sir.
We are not able to see any screen. Ashish sir has texted he can't hear anything. Can somebody from digital team can help them? Help him. You again start sharing the screen, no?
Yes,
Share
yes,
the
I'm.
screen. Yeah. Again, it is you now can go to the full screen or it is coming same.
Now it's in the slides of full screen, sir.
Okay, I think we will go ahead.
Good afternoon, everyone. I am Dr. Shishir, and with me is Dr. Sima. Today, we are going to present a case on organophosphorus poisoning. Uh, Presenting complaints: a 30-year-old female homemaker resident of Adhampur, Haryana, presented to emergency department of Medanta Hospital, Gurgaon, at 8 a.m. in the morning on 8th May 2025 with alleged history of ingestion of some pesticide. History of present illness. There is a history of ingestion of poison at approximately 5 a.m. in the morning of 28th May 2025. A bottle was brought with them which showed the pesticide to be monocrotophos. The amount ingested was 1/4 of 1 liter bottle, which is approximately 250 ml, and it was not associated with the ingestion of any other substance along with it. During shifting of the patient to the hospital, patient developed sweating and respiratory distress,
Dr.
twitching and
Sasi,
yes, ma'am.
only one slide is visible. We are not able to see second slide.
Uh,
Slide is not changing. Yeah.
Now it's visible. Now it's visible.
So history of present illness. There is a history of ingestion of poison at approximately 5 a.m. in the morning of 28th May 2025. A bottle
I
was brought
can't
with.
hear anything. I can't hear anything.
Siddharth,
I think the problem has to be fixed at Dr. Bhalla's end. While it is fixed, please carry on.
Okay, sir.
yes.
The amount ingested was 1/4 of 1 liter bottle, which is approximately 250 ml, and it was not associated with the ingestion of any other substance along with it. During shifting of the patient to the hospital, the patient developed sweating and respiratory distress. Twitching and fasciculations were also observed. There was gradual decrease in responsiveness. There is no history of vomiting.
I can't hear anything.
सर योर स्पीकर वॉल्यूम मस्ट बी लो सर, एक बार ट्राई कीजिए बढ़ा के. आपका तो वॉल्यूम आ रहा है सर.
Please
Ashish,
continue.
please increase your speaker's volume. You might have reduced your speaker's volume to minimum. Yes, please go ahead.
Uh, Primary survey. The primary survey done in the emergency department, it showed the airway to be patent. Breathing, bilateral air entry was present with wheeze and creps and auscultation. Respiratory rate of 36 per minute and saturation of 85% at room air. On circulation, there was sweaty skin with cold peripheries. Pulse was 50 beats per minute and blood pressure of 80 by 50 millimeters of mercury. The patient was drowsy and no response to verbal stimulus. There was response to pain stimulus. GCS was E2, V3, M5. Pupils were bilateral pinpoint. On exposure, the body was drenched in sweat and patient was found to have passed urine and stool. After primary survey, IV lines were secured. Two IV lines were secured. One 18 gauge IV cannula in left hand and one 16 gauge IV cannula in right hand. IV fluids was started concurrently and investigations were sent. Uh, Patient was intubated by using modified rapid sequence intubation and patient was put on long protective ventilation. Injection atropine 2 mg IV bolus was given stat. IV fluid total 1 liter IV bolus IV RL bolus was given over 30 minutes followed by maintenance fluid and the following investigations were sent. The investigations included ECG, blood glucose, ABG, renal function test with serum magnesium, liver function test, PT-INR, ABTT, urine pregnancy test, chest X-ray, plasma acetylcholinesterase level, and urine for toxicology. This was the atropinization sheet in the emergency department. Initially, 2 mg atropine was given at 8:05 a.m., where the heart rate was 50 and blood pressure was 80 by 50. The chest showed crepes and wheeze, pupils were pinpoint, and skin was sweaty. Subsequently, after every 5 minutes, all these parameters were assessed, and the dose of atropine was doubled. Like in 8:10 a.m., the heart rate, seeing the heart rate 52, blood pressure is still on the lower side, still crepes and wheeze persisting, pinpoint pupil and sweaty skin. The atropine was given 4 mg. Subsequently, at 15, 8:20, the atropine dose was increased by double, and at 8:30 a.m., the patient heart rate came to 90, blood pressure 100 by 60, the chest was clear, pupils were 2 millimeter, and the skin was still sweaty. Based on this, total atropine dose required was 62 mg in the emergency department. After IV atropine, the patient was atropinized. The patient was shifted to ICU, and while receiving the patient in ICU, the patient was received intubated with FiO2 of 40% with ongoing IV fluids and atropine infusion. On receiving patient in ICU, the secondary survey showed height of 160 centimeter, weight 62 kg, and BMI of 23.4. Temperature was 36 degrees Celsius axillary. Dehydration was present. There was no pallor, icterus, cyanosis, clubbing, and edema. The head-to-toe examination showed no significant findings. Focus was done. We showed echo good LV, left ventricular contractility, and LVOT VTI variability was approximately 15%. The lungs were bilaterally A profile, no free fluid in abdomen, and bilateral femorals were patent. A systemic examination, respiratory system, there was bilateral equivalent entry, cardiovascular, S1, S2 was heard, no murmur was heard. For abdominal examination, abdomen was soft, non-distended, and there was exaggerated bowel sounds. The CNH examination could not be performed because the patient was sedated after intubation, during intubation in the emergency, and paralyzed. Past history. There is a history of LSCS in 2021 and 2023, which are uneventful. No previous history of suicide attempts. Medical history, there is no any significant medical condition. Patient is non-smoker, does not consume alcohol, and non-vegetarian by diet. Family history is not significant. It's a middle class family. After receiving the patient in ICU, pralidoxim was started given. It was given after atropinization. 2 gram IV pralidoxim was given. It was 30 mg per kg. Based on 30 mg per kg dosing, 2 gram IV pralidoxim was given over 30 minutes, and it was followed by 500 mg per hour infusion. This was the ABG of the patient. We showed PS is 7.34, and there is a lactate of 2 and base deficit of -4. Glucose is normal, and the urine pregnancy test was negative. The hematocrit is slightly in the higher side, 41, and as saturation of oxygen is 84 at ABG. The CBC, the investigation which were sent in the emergency department, they came out, and hemoglobin was a little hemoconcentrated of 14.1. There was TLC 11,000, RFT creatinine 1.1, and urea 41. The electrolytes, sodium on the little on the higher side. Apart from that, all the electrolytes were normal. LFT showed the following, which is normal. PT INR was also normal, and the plasma acetylcholinesterase level was decreased to where the normal value is in the normal range is 4.6 to 11.5. So this was the X-ray of the patient post intubation. So day 0, on the day of receiving the patient on the ICU, the atropine infusion dose was 10 mg per hour, which is almost 15%, somewhere between 10 to 20% of the total atropinization dose. The pralidoxim was continued at the infusion of 500 mg per hour, which is 8 mg per kg per hour. Ralst was inserted, and RT feed was started. Follies was inserted, urine output was monitored, and DVT prophylaxis was started. On day 1, the atropine infusion was continued at the same rate, and pralidoxim infusion was also continued at the same rate. The patient's sensorium improved. GCS was E4 VT M6. Pupils were bilateral equal 3 millimeter reactive to light. Patient weaning was started. The patient was kept on pressure support ventilation mode. On day 2, the atropine dose was reduced to 8 mg per hour. Pyridoxine dose was continued at the same rate. Patient was hemodynamically stable. Patient was conscious following commands, and the patient was extubated after successful spontaneous breathing trial. Follies and Ryle's tube were removed. On day 4, the patient developed weakness of proximal muscles. There was increased respiratory distress, CO2 retention developed. ABG was done which showed pH of 7.16 with a pH CO2 of 92 mmHg. And seeing this condition, the patient was intubated and kept on ventilator support. So these are the investigations in the tabular form from day 0 to day 4. There is not much any significant problem or derangement in the investigations. Routinely, CBC, RFT was done every day.
Rungta sir and Ashish sir, do you want to ask them in the
No,
stepwise
let
manner?
him finish, Venkat, let him
Okay,
finish.
okay,
Let
sir,
him
right,
finish. Yeah?
right, okay.
I am listening very carefully.
So from day 5 to day 15, the patient was kept in ventilator support. The patient underwent percutaneous tracheostomy on day 12. Supportive care was given, and the patient was gradually weaned from ventilator to pressure support ventilation with PEEP of 5 and pressure support of 5 centimeter water on day 15. Patient was weaned from ventilator support to hydrotrack on day 16, and finally the patient was shifted to ward on day 17. Thank you.
Is that all?
Yes, sir.
Vikram,
Yes, sir.
do you think this is time for us or somebody else will?
No, sir. You can ask sir questions,
Right.
sir. Yeah.
Doctor, what is the name of the president?
Dr. Simar.
Dr. Simar. Dr. Simar, usually this is not the kind of response I usually give to a case presenter. But the case presentation in this case has been. Do you want to discuss also?
Yes, sir.
No, sir. You can ask the questions from the presenter, sir.
Right.
So they give the answer.
No, you see, first thing, we want to know how much time after consumption the patient landed in your hospital, in your
Yes,
emergency room.
the patient consumed poison at 5 a.m. in the morning, and patient landed in the emergency at 8 a.m. in the morning, sir.
After 3 hours.
Yes, sir.
Okay. So, did you collect samples for medical legal?
Urine for toxicology was sent, sir.
No gastric lavage for medical legal sampling?
So the patient
No
presented
blood sample?
blood as
You
such.
require 3 samples.
Okay, sir.
This is a medical legal case,
Okay.
right? You said GCS was 10.
GCS was 10, sir.
So why? What was the case for intubation? You did not try any other mode of oxygenating patient.
So the OP poisoning as such is associated with increased secretions as well as the patient has high risk of vomiting due to the poisoning as such. And with
Are you sure?
yes, sir. Increased
No.
salivation.
You require only about 25% cases of organophosphorus poisoning to be intubated. 75% would not require intubation. So you are giving an impression that probably as soon as the case arrives, we should intubate every patient.
No, sir. The intubation was primarily done to protect the airway. With the decreased sensorium, the patient might not be able to protect the airway within.
No, that's okay. That's one indication, but the GCS was 10.
Yes.
You have mentioned GCS was 10. And
Yes, sir.
even before trying one single dose of atropine, the patient was intubated. The patient would have been fine. Airway would have been better with single dose of atropine, 2 doses, 3 doses. And you could have tried any other method of oxygenating the patient.
Can I ask a question, sir?
High flow.
Can I ask a question?
Ashish?
Yes, sir.
Of course, yes, Ashish.
Can you just go back to the presenting vitals?
This is the primary survey.
Just tell me what was the pulse rate, blood pressure,
Pulse
respiratory
rate
rate,
was 50 beats per minute and blood pressure 80 by 50 millimeters of mercury.
and respiratory rate,
Respiratory rate was 36 per minute. SpO2 was 85%, sir, and temperature was
and
36 degrees centigrade.
and any
And
other findings?
there was bilateral wheeze and Krebs and auscultation, and the
Hmm.
patient's GCS was E2V3M5 with bilateral pinpoint pupils.
Okay. So what is the first thing you want to do in this patient?
First thing, sir, we need to take IV cannula and resuscitate the patient, sir, because the
Okay.
circulation is in the lower side, 80 by 50.
Next,
And sir, first of all, in primary survey, we see if the patient is able
what
to
is the next thing intervention you want to do in this patient?
uh, atropinization, sir, based on the
Did you give
history.
him this patient atropine?
Yes, sorry, sir.
Did you give this patient
Yes, sir.
atropine?
Yes, sir. Yes, sir. 2 mg.
What was the time from which this patient had come to you, and like door to needle time and door to atropine time? What was the time?
So patient presented at 8 a.m. and first atropine dose was given at 8:05, 5 minutes after 5 minutes.
How much atropine was given?
2 mg atropine was given, sir.
2 mg in a patient who is having, okay, fine. So you gave 2 mg, and then what did you do?
So after giving 2 mg atropine, the chest was auscultated, heart rate was seen, blood pressure was seen, and it was followed by another 4 mg of atropine after 5 minutes.
And
And again, the same thing was repeated every 5 minutes.
when was the patient intubated?
So the patient was intubated initially, sir. The atropine was given at the same time the airway was protected.
What was the indication for intubation?
So decreased sensorium
DCS was 10.
yes.
GCS was 10.
CS was 10.
Before
That's
you
exactly,
tried
Ashish, I was discussing with him.
atropine,
The same thing
yeah,
I was
I heard you,
discussing with.
sir. I heard you.
Can I
I
interrupt?
just, I just wanted to know the timeline, because the impression given is GCS of more than 9, you intubate. You don't give atropine, you intubate first. That is not something which is correct.
Uh, Sir,
And
can I?
the and the sorry, the interval between ingestion and coming to the hospital.
3 hours, sir.
3 hours, he says.
No, 3 hours. Who told you 3 hours? Patient came to you at 8 a.m. in the morning.
Yes, sir.
8 a.m. This
Yes.
means the patient would have taken it at 5 a.m. in the morning.
Yes.
Who gave you the history of 8 a.m., 5 a.m. in the morning?
So patient's family, sir.
No, did they see that?
Uh, they reported approximately 5 a.m. in the morning.
That is, see, you can't go on a hearsay.
Okay.
Who found the patient? Was the patient unconscious? Who was with the patient at that time? Somebody tells you the patient has taken something 2 hours prior to coming to the hospital. You believe it? 8 a.m. if the patient has come, maybe this patient has taken it at 12 in the midnight. You don't know,
Yes.
because that that information is very important if you want to start oximes. If you say it was 5 a.m., then there is some rationale. You may still try giving oximes, but if it is beyond 3 hours,
No,
no
Ashish,
oximes.
let us grant it to him, but there are lots of discrepancies. Simar, one thing, you cannot intubate every patient of organophosphorus. You have to, the first thing you do once knowing that patient is organophosphorus poison, the first thing you do is give atropine and watch the response. These patients respond very, very fast. The first response is very fast. The patient may relapse time and again, but the first response is, what is your target when you give atropine? What is atropinization? What are you
So,
looking at? What target you are trying to target?
the initial target is clear chest, heart rate of greater than 90 beats per minute, 80 beats per minute, systolic pressure greater than 90, uh, pupils no longer pinpoint.
I'm sorry, Simar, that's not atropinization. That's not the target. Only target is heart rate. Some people will look at drying of the secretions. Heart rate and drying of secretions. No blood pressure. Blood pressure is not the target here at all. It's not part of atropinization target. So you are targeting what is the toxidrome of organophosphorus poisoning?
So the toxidrome of organophosphorus poisoning, it presents as muscarinic symptoms, nicotinic
No,
symptoms,
no,
and
no.
severe.
I'm talking about toxidrome. I'm not talking about muscarinic, nicotinic, central. Toxidrome.
So basically, the constituent of signs and symptoms which is seen during OP poisoning, which includes increased sweating,
There is a
salivation.
standard toxidrome. There is a standard toxidrome of meiosis, secretions, hypotension, and bradycardia. That's the standard toxidrome of organophosphorus.
Okay.
So we don't target meiosis at all. We target
Clear chest.
heart rate and secretions. Hypotension is not treated with atropine. What is the cause of hypotension in these patients?
So the insensible losses, there is huge amount of insensible loss due to sweating and all the secretions, which can lead to
So that
hypotension.
you are compensating with fluid,
IV fluid.
not with atropine. And you have started use ringer, not NS.
Yes, sir.
Why did you paralyze this patient? What was
For
the need
him,
of paralysis?
so it was
Why don't we don't only very sick patients of ARDS are paralyzed.
so it
We
was
have good
paralyzed.
sedatives which can be given to maintain. There is no case of tracheostomy here. Why the patient was tracheostomized?
For weaning issues, sir. Patient had more than
No.
10.
Why? When which patients are subjected to tracheostomy?
So if the requirement of ventilation is, if you think that the requirement of ventilation is prolonged for easy weaning of the patients,
Exactly, Simar. I agree with you on that point, but it is predictable in organophosphorus, but it is not going to be more than a week or 10 days.
so actually even after 7 to 10 days, the patient could not be weaned. So that's why after 7 days
So
of
maybe 2 more days. Maybe if you are still making sure that the patient can be weaned off in about 2 weeks' time, you don't have to do tracheostomy.
okay, sir.
We don't have to go by, we are not slaves of few lines in literature.
Yes, sir.
So why did you use ringer? Why did you tracheostomize this patient? in the first place, even intubation is not indicated at all with GCS. You yourself have committed GCS was 10. Dr. Sweta was wanting to talk something. Dr. Sweta, yes?
Yeah, sir. Actually, patient was intubated in emergency department. We
No,
also
but
yeah, sir. Her GCS was 10. So and she's also protecting airway. So there was no indication of intubation at that point, sir. Yeah.
yes.
Yeah.
So there was no, and you have not picked up sample for cholinesterase before giving pump. It becomes useless after you have started pump.
It was already
It was sent from the emergency.
emergency department, sir. Yeah.
It
Plasma
was
cholinesterase
sent for
and
emergency.
in
That's
toxicology
okay. That's
and drug
okay.
toxicology already sent
Now you
from
see,
sir, emergency
plasma
department.
sterile cholinesterase levels are not valid.
Yes, sir.
I don't agree with that.
It's not significant.
No, it's useless. So which sample you want to send?
RBC cholinesterase.
RBC.
RBC cholinesterase.
Again, that becomes
But it is
infectious.
not available in our hospital, sir. Actually,
No,
RBC.
no. You see, it may not be available in your hospital, but if you want to do cholinesterase, you have to
Yeah,
see.
so
You just have to see. Send a blood as you collect for CBC, the same blood.
yes, sir.
You can send to lots of samples. Lots of tests are not available in every hospital. So there are labs around. They say give you reports in good time. So it's a, and you have been doing all investigations every day. What was the need of doing LFTs, RFTs every day? Electrolytes I can understand. When patient is passing urine, patient is not having any problem related to liver, and you don't expect that to happen.
So liver enzymes were not sent. It was only sent during the initial visit to the
No, no, you
emergency.
have
After
shown that table.
that, sir,
Urea,
only
creatinine.
the yes, sir, only the RFT and the.
No, but it does not sound very healthy. No, if even if you have done, you don't have to mention here
Sure, sir.
platelets, and you when you want to showing these things, that means you are expecting something to happen there. And do you think it was a severe case of organophosphorus poisoning?
Based on signs and symptoms, yes, sir. The patient had bradycardia with
So
hypotension
would you
with.
prefer a continuous atropinization or a intermittent wait every time?
Continuous atropinization of bolus.
But you did not practice that. You did.
So atropine
The
infusion.
philosophy about prelidoxim has also changed of late.
Sorry, sir.
Prelidoxim is not used as much as we don't use prelidoxim, but that doesn't mean if I don't use, you also don't use. Right. So, the best target is heart rate, maintaining heart rate at around 100. And that's how you titrate atropine dose with heart rate. That's it. Secretions will automatically dry up. You should have tried at least HFNO. If you don't have HFNO, you should have tried high flow. So I don't think this is the best case scenario possible with organophosphorus poisoning. I'm sorry,
Rungta sir.
Simon, that's usually I don't. That's not. That's unusual response. I am forced to give.
Yeah,
I am
Rungta sir.
disappointed.
Rungta sir, can we actually ask the most common questions which are expected in the exam? The both students are
No,
prepared.
yes, that's it. That's exactly, what I am discussing answers most of those questions. What is the toxidrome? What is atropinization? When do you give pump? When do you give samples for cholinesterase? What sample of blood it should be sent for cholinesterase? monitoring, when do you intubate, what are the indications for intubation. What was the second happening which required second intubation? You have not talked about it.
Sir, it was due to most likely due to OP-induced intermediate syndrome, sir.
Yes, intermediate syndrome is specific to organophosphorus poisoning, but
Yes.
that seldom happens so early on day 4, 5, as you have mentioned.
Yes.
Usually, it happens after, that's the standard time is second week. That is why I say when organophosphorus patients recover, he must be observed for another 24 to 48 hours before he is discharged. And you see, the decision to do a tracheostomy and a PCT was bizarre. I don't remember we have ever done tracheostomy in any case of organophosphorus poisoning in my entire career, handling more than 300 cases of organophosphorus poisoning. Only 20% cases of OP poisoning require intubation. The sample
Roonghta sir,
was, yeah. So
Roonghta sir,
now let us move ahead. What is organophosphorus and organochlorines? What is the difference?
yes, yes.
There are two compounds, two types of
Yeah,
compounds,
Dr. Simar, you can actually explain what are the different compounds available in that
Sir,
toxidrome.
organophosphorus compounds, they are either nerve gases or pesticides. In pesticides, we have dimethyl compound and diethyl compound. So in
Okay,
Right.
dimethyl compound, we have compound like malathion, penthion, and dichlorvus. Or in
okay.
and in ethyl compound, we have uh, parathion and chlorpyrifos. The
What
so
is chlorpyrifos? Is it is a organochlorine or organophosphorus?
Dr. Sisir, you
organochlorine,
can
sir.
also reply. So both
You
candidates
know,
please involve actively.
right. This X-ray chest that you are showing is absolutely normal.
Yes,
Sima,
sir. Yes, sir.
are there any problems in this X-ray? Do you think this patient would require intubation?
Sir, patient was hemodynamically unstable also, and then he was respiratory rate was also increased, and he was in respiratory distress and drowsy also. So that is why we intubated that patient.
No, no, no. Simmer, you can't intubate. You can't intubate for these reasons. Hemodynamic stability, BP was 80, and one bolus of, you have not required any use of vasopressors at all. GCS, you have mentioned 10, you paralyze this patient.
Sir,
You knowing very well knowing that organophosphorus have central actions also. So how would you differentiate if these any central problems are occurring with this poison?
Sir, for rapid sequence intubation, I had paralyzed that patient,
No,
but
no, 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 you can't do that. Absolutely, you can't do that. How will you judge whether central problems of OP poisonings are taking place? If you paralyze the patient, you have
yes,
blinded yourself.
yes, sir.
Um,
Yes, sir.
So you see, you should, if you wanted to intubate this patient, you should have mentioned GCS was 8, 7. Now let's proceed.
Yes,
Right. So, and you should have brought an X-ray with pulmonary edema sort of picture. Many of these patients, most of these patients on arrival would show a X-ray chest, which is typical of something like pulmonary edema, which is not actually pulmonary edema. These are pictures of aspiration.
True.
which disappear very, very fast with atropinization.
True. Mostly they had a very honest, transparent case presentation, sir.
No,
And
no,
they
that's
got hold of
okay.
a very strict
But
examiner, very, very
again,
strict examiner.
you have invited me and Dr. Bhalla.
Uh,
Our duty is to
sure, sir.
rectify.
Yeah, sure.
Yes.
That doesn't mean that we don't love them.
True, true. True, sir. Please move on, sir.
Please
I think.
continue, sir. Yes, sir.
Right. So, you are taking it in a different direction. So, you see, I have personally handled 300 plus cases of organophosphorus. That's, I know, A to Z of OP poisoning, and that's probably one reason why Bikram has invited me or Venkat has invited me. So there
For
is,
toxicology, I think we all
Yes,
look
sir.
forward for you, sir.
so, I say zero tolerance for mortality in OP poisoning. Zero tolerance for mortality in OP poisoning. One, I don't use palm. I don't intubate the patient unless absolutely needed. And most of our patients who are intubated are with very poor GCS, frank aspiration pneumonia, of course, bad hemodynamic picture. Now let us move. Why did you not talk about skin wash,
The
change
patient.
of clothes?
Yes.
Decontamination.
Yes,
Decontamination.
the primary mode of injection, the only mode of injection was intake, sir, oral intake. There was no.
No. You see, they are secreted in skin also. You never know what had happened. If the lady had sprinkled a lot of substance on her body, change of cloth is a primary intervention you do on arrival, and that must be mentioned. We do change, dress of every patient once they arrive in ER, but that must be mentioned specifically. Another thing I want to understand from you: precautions you and your resident and your nurses should take while handling a case of OP poisoning.
So, PPE, personal protective equipments must be worn, which includes
What personal protective equipment you
gloves,
are talking?
Glove.
gown, as well as protection for eye.
So that no, but I'm interested more in hands.
Yeah,
Yes, sir.
gloves.
Gloves.
Thick gloves, not the routine vinyl gloves.
Yes, sir.
And if you only have routine vinyl gloves, at least 4 layers. Because these organophosphorus substances are known to penetrate through the vinyl gloves. And there are cases reported where nurses have developed corrosion of their palms. Anyway, so that must be taken into account, right? And palm, how long palm was continued? What was your target cholinesterase? What was the first thing you wanted to see in your patient before you thought that now you see the patient is coming out? I'm not talking about intermediate syndrome.
So, palidoxim is given after atropinization of the patient. Once the patient has reached atropinization, once the atropine, our targets are missed, achieved, only after that palidoxim is given. 30 mg per kg initially bolus dose over 30
You
minutes is
see,
given.
pralidoxin, that's okay. Pralidoxin should be started only if the patient has come within 4 hours. Otherwise, it's useless. One. And now, what is the case for DVT prophylaxis in this case, young lady?
Sir, she was bedridden, so that's why DVD prophylaxis was started.
All cases who come to you and they are bedridden in your ICU or emergency, do you give them DVT prophylaxis?
If they do not have any
I
contact.
take the subject to Dr. Ashish, Venkat, Vikram, even Dr. Shweta.
Yes, sir.
Would you do a DVT prophylaxis for all
Actually,
cases?
fast hug PIDS, it's our ICU protocol. And So
I won't agree with that. If organophosphorus poisoning 25, 30 years old lady without if she is given DVT,
actually
that's
was
not the right protocol. I'm sorry.
actually, sir, she was intubated on ventilatory support, so that's why we have started DVT prophylaxis. And
No. There is no indication for DVT prophylaxis here. Again, you see, the audience will go with a very wrong impression. I am afraid if they would start doing DVT prophylaxis for OP poisoning patient, if they are intubated. What is your opinion, Venkat?
Most of these patients we actually review with the DVT risk. If they have been on a prolonged
Yes, that's
ventilation,
exactly. At least you go through that exercise, and the patient will be there only for about 5-7 days. 1 week is the optimum time, maximum, unless the patient develops, complications and, of course, intermediate syndrome, which is the mostly that was most common with Eldrin. Eldrin is now gone. Is no more in production. So DVT prophylaxis again, does not sound very healthy decision. I don't want the audience, the participants to take this idea. Nowhere in literature of OP poisoning it is mentioned that while intubating this patient, after intubation, you should give DVT prophylaxis to this
so
patient.
not
No,
for OP poisoning, for any intubated patient. And
no, madam. No, Sweta, I won't agree with that. I can argue with any team.
sir, it's our ICU protocol.
No, that's that. I'm not. I don't talk. I
If
don't want to talk about the protocol of your ICU. That's not my area. I'm not empowered. But as examiner here, I'm definitely
yes,
sure that no DVT prophylaxis is
yeah.
required.
So, Dr.
If
Sweta, what
if you if you
Dr.
want
Ronta is
to
trying.
do it, you do it in your ICU, but don't mention here.
Yeah, so what Dr. Rungta sir was trying to emphasize on here is
yeah,
it's not just a day of admission when a patient with OP poisoning needing ventilation for airway protection, but
yes,
what happens if the patient remains in the ICU for a prolonged period, taking a risk increase because of the immobility or a stasis without being not able to move out of the bed or any mobility or all that, then that all accumulates to a risk of DVT, where we generally use a pneumatic compressive devices, physiotherapies and all. And then probably if you have a risk where you can't move, so he says that it's not the OP poisoning or a ventilation or initiation of an intubation, but the risk factors which accumulates over a period of weeks or days where you actually consider the risk. So I do understand all of us follow the same FASTag BID, and that FASTag BID says look for them, look for all of these
Even
needs and
Venkat
requirements.
Fast Hug also does not recommend DVT
Yeah, it
prophylaxis.
is all look for that.
So,
Need of a DVT prophylaxis in your medical intensive care unit has to be evaluated. Is
To be
that is
evaluated,
the point?
yes.
so now what is intermediate syndrome? How does it happen, Simar? Let's come to that.
Uh, So intermediate syndrome, it happens after the acute cholinergic crisis has stopped, after the patient has overcome the acute cholinergic crisis, and before development of the delayed syndrome. So that's why it's called as the intermediate syndrome. The patient presents with proximal muscle weakness, flexure of necks, cranial nerve palsies, which can progress to respiratory distress, and patient might require intubation for that, sir.
What is the treatment?
So it's basically supportive treatment, airway, securing airway, providing ventilation to the patient. Usually suffices. Usually it lasts for 2 to 3 weeks, and during which the patient overcomes and can be weaned from ventilator.
So the only treatment is patient ventilation. That's all. Nothing else. Now, you see, what maximum dose of atropine you can give to the patient?
So there's no as such a maximal dose quoted that can be given. Increased by is doubled every 5 minutes, seeing the response of the patients. There have been studies which have shown hundreds of more than 100, more than 200 mg of atropine that has been required. There was a study which showed even around 31,000 mg of atropine required.
We have used maximum up to more than 3,000 ampoules in one
Yes, sir.
patient. Right. Can you put it in one sentence? No dose of atropine is too high
Yes.
to manage a case of organophosphorus poisoning. What are the nicotinic effects of OP poisoning?
So it can initially it causes twitching and fasciculation, and this is followed by paralysis of the muscle.
Good. So when will you discharge this patient?
Uh, so this patient was discharged after the patient recovered from the intermediate syndrome, when the patient could maintain on the room air, and patient was hemodynamically stable, patient was conscious, oriented, following commands. So all these characters were met before the patient was discharged.
Shweta, ringer is also part of your protocol.
No, sir.
So what was why particularly ringer was used? We hear about ringer.
We use a balanced solution. It's
All right.
balanced solution.
So from our side, it's all done. I hope so. You know, these days you haven't talked about gastric lavage. Simar, you want to make any comments?
So gastric lavage is done when the patient is presented after within the ingestion of 1 to 2 hours. Then gastric lavage is not routinely done, and it has shown that it has no mortality benefit or not such benefit for
That's
the
that's
patient.
that's that's a very good answer. But would you consider doing a gastric wash later on, say after 12 hours or say 6 hours?
No, sir.
So like for medical legal purpose, you are
No,
talking.
no, no, no. Many of these organophosphorus compounds have been known to be secreted in stomach after hours, even when the patient is recovering. So some authors do recommend a gastric wash after 6 hours, 12 hours. I'm not saying you do it, and it's no folly to have not mentioned about it, but I'm trying to share with you some additional information. So I will sum it up, Venkat.
Yes, sir.
So the
So,
presentation style was good, but the management was not the classical I would like to do in my case, or I would like to hear from any resident who is doing or even young consultant. So primary survey, that's okay. But first thing you do is give the antidote to collect, always collect samples for medical legal purposes, whatever samples are required. Send exact sample for what is needed. We need RBC. And Sweta, I would be surprised if Medanta cannot get RBC levels of cholinesterase in few hours time. I would wonder if that would be the case. Then you stabilize the patient hemodynamically. Avoid intubation as much as possible. I'm repeating it 3 times. Do it whenever it is absolutely needed. GCA is the first thing required. These days, HFNO is a wonderful equipment which does the trick very early on, and most of these patients would not require intubation. No, there is no case for tracheostomy. in any case of unless things have gone really wrong and patient is lying in ICU for more than 2-3 weeks and patient has developed ARDS, complications, secondary infection or sepsis, which seldom happens. So target atropinization targets, which is mainly heart rate. Number 2 is secretions. We don't look at meiosis at all. Meiosis may sometimes take hours and days, or sometimes it responds very, very early. Don't discharge the patient after recovery immediately. Just ask him to wait for at least 24 to 48 hours. But even when you discharge at any time, tell them there is a possibility of this patient developing intermediate syndrome. And these patients do not give sometimes when they come with intermediate syndrome because it was a case of poisoning. If they come standalone with intermediate syndrome, many patients don't give you a history of poisoning. They want to hide that. And these patients end up getting treated as GB syndrome. Primary poisoning was treated somewhere else. They have developed intermediate syndrome after a week and lands up in another hospital. Don't give the correct history. So nobody would even think. That's all from my
So
side, Venkat.
before closing, thank you, sir. Before closing, I request to Dr. Sweta, please give your input and take questions from the chat box. There are 3 and 4 questions in the chat box. So,
So one question is from Kartike. It's seizure in OP poisoning. So seizure in OP poisoning can be managed with benzodiazepine 10 milligram. So we use benzodiazepine for seizure control in OP poisoning.
sir, you want to,
And second,
Rumta sir, you want to add something?
No, that's the correct answer. Yeah, yes,
Okay.
yes, that's the correct answer. In all poisonings, benzodiazepines, midazolam is the standard compound that we use for controlling seizure.
Another question is, sir, how long must palm be continued?
The philosophy about palm is hit early, hit hard, keep on hitting. That's the basic philosophy. The palm promoters or palm passionate clinicians say. Means not in favor of use of palm. I feel that palm is no, I've not used palm for last 15 years. And last 100 cases have gone without palm, without any mortality. So, but that cannot be the case that yes, still people would use palm. So hit early, hit hard, keep on hitting until you are absolutely sure that the patient is out of woods. And cholinesterase levels in RBCs are okay. There is no residue of OP poisoning left.
Next.
any question I can't see, and I can't see any other questions.
Yeah, what antibiotic, sir? Someone asking is what antibiotic if you want to give the antibiotic.
No, there is no case for antibiotic.
Antibiotic, no indication of antibiotic in OP.
No antibiotic.
And if you want to use the glycopyrrolate infusion, then what will be the dose?
Right. I'm not the best person to describe glycopyrrolate dose. There is no, unless there is toxicity of atropine, which is seldom observed. The most important toxicity that we have observed is psychosis. We seldom see fever with atropine. If fever is at all there, it is of very mild nature. But atropine crosses blood-brain, does not blood-brain barrier is the major issue. Glycopyrrolate crosses the does not cross the blood-brain barrier. Therefore, it would not cause all those side effects which are to the discredit of atropine. But I'm
And then
not.
last question, sir, how and when to taper and stop atropine before atropination?
No, you see, you stop atropine when you are absolutely sure. From continuous infusion to you can move on to intermittent SOS basis. The target is to maintain heart rate around 100, not 80 or 90. So if it is maintained for fairly good time, sustained around 100, you can withdraw, wait, watch, and you may require occasional dose of atropine, not out of conviction, but out of you don't want to take any chance.
So one question is from Dr. Anjikia. She is asking arrhythmia and OP poisoning. So arrhythmia and OP poisoning are common because there are QT prolongation and so arrhythmia, VT, ventricular tachycardia are also most common in OP poisoning. Sir, what?
Ventricular tachycardias may occur because of atropine. Sometimes, rarely. You know, OP poisons cause bradycardia. So, incidence of VTAC would be least expected.
So time is up, sir. Now, Dr. Sweta, if you want to say something before closing, then I request to Dr. Venkat Kola. Dr. Venkat?
Before you close, Vikram, I want to say a few words to
Yeah,
Simar
yeah.
Anand.
Please, sir.
Yes,
Yeah.
sir, please. Sir.
Simar, I have
And Sisir. Simar and Sisir,
I
sir.
have performed my duty as a teacher,
Yes, sir.
giving you direction. At the same time, I admire your ability to argue and present your case, and still give reasons why you did what you did. So that's good.
Sir, last, can I ask one question?
Yes.
Just one. Suppose in a practical clinical scenario, a patient of OP poisoning, it lands up in the emergency. The patient is just responding to pain on pain command like E2 on pain. The patient is opening the eyes, making little bit of sound on pain. The patient is just localizing pain, and the patient is actively vomiting because we know emesis is a symptom of OP poisoning, and also increased secretions of patient has a lot of secretion in the oral airway when the patient is actively vomiting. So how would you suggest to manage such case when the patient is actively vomiting?
Same way as I've talked. I will not think of intubation.
Okay.
That was the question probably you were trying to extract from me.
I think,
So, yeah.
yeah, Dr. Simar, I think what Dr. Runta is re-emphasizing from the beginning of this discussion is the indication scientifically remains few. Some of the times where your emergency colleagues may take the decision of airway protection much before you even know, but the standard indications for intubation remain or airway protection remain the standard, including like when we see a post-ictal state, we don't intubate them even though the GCS is low. And here, if we see a hypoglycemia patient, we do give a 25% dextrose. What Dr. Mumtasar is trying to emphasize is if a patient GCS is 10 and above, and you have an option of giving an antidote, which can actually reverse some of its neurological, and please try that. In spite of that, if the GCS remained low and you have a airway protection concern below 8, you take a protection. And remaining hypoxia, secretions and all, that is more of a because of your cholinergic effect of the secretions. So that can get dried up by your atropine. That's what we do. If I have somebody's unconscious, you give a 25% dextrose, they get normal. The GCS was 3 before, but we don't intubate. So he's trying to emphasize, and that's what we learn in this kind of sessions where teachers like Dr. Rungta teach us, including me. Dr. Sweta, we all have been teachers for him, and that's what we learn from him. And I actually appreciate both the students who tried to bring the case. I do understand the airway protection and all must have been done in emergency room much before we even
No,
understand
that would
and
have
know.
been,
But this is the
they
flow.
could have escaped very easily that even before we could, do something, patient was already intubated by the emergency guy. That would have gone
Yeah.
very well.
Yes, sir. This
So,
that
sir,
could be the good
real
answer.
world, in real world time, when there is an emergency department, the initial few hours of research station are generally taken care by them,
No,
and
that's
then
okay.
some of the
That's okay.
ICUs
So,
get involved. We get involved, and sometimes even we just receive the patient in ICU after shifting to ICU only.
right.
So, but
I
I think
further
this is all
suggest
learning curves. I also learned a lot of things.
Simar Anand, I
Sir,
suggest
please go ahead.
please go through the position
Yeah,
statement of our society, which was published in
yeah,
March IJCCM last
2025,
year,
2025.
where we have
Yeah.
very clearly explained what are the indications for intubation in any toxicology patient.
Yes.
So as such, as Sir said, OP poisoning doesn't increase the risks of any of these hypercoagulable states or a thrombotic states, but a prolonged intensive care course can cause all of them, which we were all discussing. And very clearly, he mentioned about the doxydromes. So most of the times, what I believe is all the students get the case which is known to them. It's a OP poisoning. It is either a case of ARDS and all. They wanted you to how you are approaching. So that's what Dr. Rinka sir said. We know all the case. You have a senior clinician with you, Dr. Sweta, but still he can actually drag all those points out of this case. Thank you, sir. Thank you very much, and I
Thank you very
congratulate
much. I
both
have
the
enjoyed.
students.
Thank you, sir. It was a great
Yeah,
learn.
yeah. We all learned, sir, not that student.
No,
I
no,
think we would
no,
have
that's
been
fine.
performed equally bad if we would have been in their position. Many learning points from you and practical learning points, sir. Thank you very much.
Yes,
Right.
sir.
Thank you.
Thank you.
Thank
Thank
you.
you.
Thank
Thank you,
you.
Good
sir.
night.
Thank you, all of you. Thank you. Thank you, both the student.
Thank you.
Thank you.